So let me introduce my, super friend Henrik, who is a founder and he is a technocrat and a health specialist. Did multiple number of work into health industry and technology domain, as well as he has. I mean, his team have done super remarkable work during this crisis time for COVID-19. They have developed a solution for remote testing to help the health workers so that they become safe during the virus pandemic situation. And they are doing massive work in Europe, and most probably they are entering into Australia very soon. I'm blessed to become a part of their own team, and happily we are trying to connect with different kind of market segment. They are trying to do super awesome job for India as well. Although India got 1.3 billion people strength, but their main target is very specific, which is health worker, as well as the remote testing module actually helps an individual to test themselves using the remote testing method. So Henrik, over to you. I'll keep myself in mute mode. I'll be managing the participants and the chats. So the way usually our webinar happens, all of them, they know how it happens. They will not put their microphone on, rather they will be asking question in common chat box, or they will send private message to me, and I'll give you the question later on once it is done. It's complete 30-minute slots that we have. So over to you, my friend.
Okay, thank you. Hey guys, just a few words about myself. I've been working as a healthcare architect and consultant in Danish healthcare IT for many years. I've been behind the National Danish Health Portal that was launched in 2003, which means that's a very long time ago. I was also later involved in delivering and developing the nervous system, the integration platform for all communication in the Danish healthcare IT between municipalities, regions, government, and private doctors. So it is kind of my DNA to work with healthcare IT, so I've done that a lot. And since 2013, I developed a healthcare platform for remote patient monitoring. And what I'm just going to do now is I'm going to take you through a few slides. First, I'll show you the basic platform, which is sort of like a development platform for telehealth, the Linux of telehealth. I will show you how that looks from high altitude. Then I will dive into the actual COVID-19 solution we have done and just give you a brief overview about that. And that should take about 10-15 minutes, and that should we have time for questions after that. Okay? So let me just share my screen. So the first I want to show you here is the system we have is cloud-based. It's cloud native, and there is a portal for the clinicians, and there's an open source app for the patients, which means that the organization we work with, we typically do white label. They get the source code and they can build their own app on top of ours. And then there is a protocol configurator which can be changed into any kind of protocol. So today the pandemic is COVID-19, but maybe in 2 months we will see a SARS-25 pandemic, and then we need to reconfigure the system to a new protocol, and this can be done interactively within a few minutes. So this is a very powerful tool. So the protocol configurator is something that is done by the doctors and powers the doctors and the clinicians to change the protocol when it updates. If you get new information about the COVID protocol, it can be updated for entire population in a few minutes. So this is a very powerful tool to keep getting the data that is needed without going back and redeveloping it. So this is the most important part of what I want to talk about today, because this is ISO 13485 certified the platform for telehealth. And this is where the things start getting complicated, because there are so many systems out there that has been developed and sprung up overnight, like popcorn companies that say, hey, we can do telehealth, hey, we can do telehealth. But what you want to look for, if you want to engage with the telehealth system, it's very important to look for the quality management system beneath the surface. So your due diligence must be very, very, extensive in the work that to find out how did your software come to life? What was before the software I'm seeing in front of me? So do you have quality management? How can you do rollback? How can you do automatic deployment in the cloud? And how has your code been developed? And what are your quality management system? And all these things are key to spotting who are brand new, very, very young and unmature systems that you do not want to put in hands of patients and doctors, and which ones have a track record that can ascertain that when the doctors uses it on patients, then there will be no mistakes. The patients won't die, and they will know what they're doing all the time. So this is key. Background quality management, and you will be looking at all the stuff beneath the iceberg. So forget the design and the usability, look beneath the iceberg. That's the important lesson for today, I think. So let me go over to the COVID-19 solution and just show you that briefly. So the COVID-19 solution side, we have been so fortunate to get RGit on board this fantastic solution. Is basically a configuration of the base of the underlying platform. And since the underlying platform has more than 6 years of experience with heavy pulmonary monitoring of COPD patients, we know a lot about this. So we really know what we're doing, and we have ISO certification and has a very solid quality in the platform. And this is important because when you put in hands of doctors, they must know what they're doing, and they must be able to trust the system implicitly. So when they give it to patients, they will not die because bugs in the software. And this is solid, and this is one of the reasons that RG chose to join us, because we have a solid quality platform underneath this. It's very important. So the results we've seen over the last 6 years is that we have saved 35% of the patient cost for heart failure. We have seen up to 50% saving for pregnancies, and a lot of savings in COPDs as well. So there can be no discussion that the last 6 years give us a platform that works. It really works. We know it works. We don't have to discuss with anyone if it works or not. We have this documented by scientific methods and articles published. So there's no discussion about this. We can start discussing, okay, how should we make this work for COVID in your country, in your organization? And the platform in question is very simple. It is a configuration of the basic platform you see on the left-hand side. And this is the patient pathway that is used to dictate which questions is asked for the patient and find out which answers give alerts for intervention and which measurements give alerts for intervention. And based on this configuration, this is visual programming, we generate the app. So the app is generated because of the actual configuration. So if you change the configuration, then the app also changes, which means that whenever you change the configuration in the background, the patient will experience that now I have new questions, I have new regimes. And that means that if you want to have a COVID-19, a SARS, a bird, an Ebola, or dengue fever application for monitoring, you just create that configuration and then you generate the app for that particular purpose. And then the patient will get that app and they will have the experience that this app is based on monitoring dengue fever symptoms instead of COVID-19 symptoms. And because this is a configuration in the backend, we see a consolidation of data going into one backend instead of 60 different apps. So from a hospital point of view, they only need one backend. The patients will see multiple different apps, so we still retain the versatility in the apps, but we do get the consolidation in the backend. And the training for the nurses, it's much easier because they only need to learn one system. The doctors can use the same system for different purposes, and we still consolidate in the backend. And this is extremely important because if you speak to a hospital today, they say, oh, we have 60 apps and oh, we can't find out that it's too confusing, so many apps. Each patient that has diabetes and heart failure, they need to have 2 or 3 apps, and that's no good because they can't do it. So what we have documented is that one app with very simple user interface is what you need because the patients want to have simplicity in their hands. They don't want advanced technology, they want simplicity because that works. Anything that has to go into a complicated healthcare system has to be extremely simple. So my entire 6 years of developing has been about quality management and taking away complexity from the user and from the process of using the system. And it works. So the actual COVID-19 system, this was what we presented to RJ when he joined, is an anonymous screening platform that is based on also programmable questionnaires with programmable logic. And the answers for this goes into real-time statistics. So you can actually see the curve being plotted real-time when you set it up. And the result of the screening is either green, yellow, or red, which means that the result of this screening gives you access to sign on automatically for enrollment in the patient monitoring system. So if you are qualified, which means that you have symptoms, then you can enroll automatically and you get an email with a link to the website where you can download the app or use the web app to give results. And this gives you access to the monitoring app where you can be monitored twice daily, and you can even use some technology for getting respiratory rate and blood saturation of the videos of your face, which is brilliant technology. But also here, when people use it twice a day, we can see the real-time plotting of the symptoms, so we can follow in real time how many is using the system, what kind of symptoms do we have, how many has logon errors, how is the fever doing in general. And so we can see any kind of search that will be trending will be seen right away, immediately. And on the right-hand side, you can see all those who have fever or severe coughing will be flagged as a red alert, which means intervention is required, which again means that the nurses will intervene on these patients if they have these kind of symptoms. But if the patient does not have severe symptoms, which is the majority of the patients, fortunately, they will not be flagged for intervention, which means that they will be enrolled in the system, they will be monitored, and then they will be exited after 3 or 4 weeks if they do not have severe symptoms, which means that we process an enormous amount of people, but we only flag those who actually have severe symptoms. And this is the life-saving important part. We need to make sure that we always catch those that has symptoms so we can pull them into the healthcare system and use our sparing resources for the right patients at the right time. Whereas all those who feel worried about themselves not necessarily have to go anywhere because we have them in control. So we can tell them, don't do anything unless you flag out on these symptoms. And that's important because then we flatten the curve and we use the healthcare resources effectively. And this is what it is all about. That's the important part. So the patient flow is automatic. They are enrolled in the startup when they sign up for the screening, and then they are processed through the flow. And after they have been through the flow for a while, they are exited and evaluated. And an important part here is they are only ever intervened on if they have fever and dyspnea, like harder breathing. And that's the only thing that triggers the nurses. And this gives us the ability for one nurse to monitor maybe 500, 1,000 patients a day. So in ballpark figures, that means 200 nurses and clinicians will be able to monitor 100,000 people. And this is the kind of scalability that is required if we have to have any impact on the population. And now we're seeing, especially that the weak persons, the ones with heart failure, with COPD, with cancer, with high age, with asthma, any kind of chronic disease, they are in risk of being infected and die. So now, to avoid that people are dying in their homes, which is happening right now, we need to go out there and put this system into play to make sure that we can monitor those who have the weak in the society, because they don't dare go to the hospital. So even if they have COVID-19, they still heard that it's far dangerous to go to the hospital. They'll stay home and they'll die home. And we see people dying without knowing that they have COVID-19. So this is the way we can stop it. But this is just an so kind of like an overview of this system that would actually work, and the one that we have Arijit on board with. What I really want to talk about today is how do you spot those that don't have something that actually works? How do you see through the blinding light of brilliant user interfaces into the mechanics behind? And one of the things you want to ask about is, have you got automated deployment? What is your average availability? I can document an availability over 5 years of servers that has been non-stop available with an average availability of 99.985%. So do these companies have clients already? What have they shown? Do they have automated procedures? Do they have quality management in place? How is their references? Have they done clinical trials? And do they actually have run installations where you can see and evaluate for yourself how it works? If these factors are not present, then you should not deal with these people unless you are very, very open-minded and don't mind things going awry. What you will see is companies that say, well, we can do this and this and this, but as soon as they hit 500 patients, the system start becoming erratic, it stops scaling, and you need to do patches and patch releases because they find errors, and the patch releases makes it all more unstable and things go to hell. And I am terrified that the business of healthcare will be tired of a bad telehealth solution because they get in the hands of people who haven't done a real good job. What we need now is to help the healthcare getting the right systems in their hands so they will see this as a good and qualified tool for providing healthcare remotely, and avoid the situation where they come in the hands of people who don't know what they're doing, believing that they know what they're doing, and then become disappointed and step away from telehealth. That is the biggest danger I see right now. And that's why I want to have this message out to you guys. Be aware what you do and who you do it with, because it has impact on lives. Okay, that's it. Let's go to questions.
Okay, so I've got a question from Abhishek Kumar. Abhishek is asking, Okay, so Abhishek is asking, what is the accuracy rate of your app this will provide, right or not? What is the question?
The accuracy of the accuracy is absolute, because what you're looking at is symptoms. And if you get a symptoms from a patient with a reading that says his temperature is more than 38.5, then we will flag an alert. What you will know is that if you use a thermometer in the home, it may not be calibrated. So we have two kinds of alerts. We have both the one when you exceed the threshold, but most importantly, we have one that evaluates the increase of temperature. So no matter how the calibration of the device is, we actually catch the fever coming up, and then we flag a red alert, and then we get them. So we have different ways of getting sure we have the symptoms flagged, so we get people into intervention.
Okay. A nice question from Sumanto. He's saying, in a developing country like India, who have got more rural areas, so there may be some internet connection issues. So how will you reach them?
So the way I would reach them is if they have a smartphone and they have access to internet, then we can do that, because the requirements for what we do is only a web app for the basic implementation. So the bandwidth necessary is almost none. If you do not have internet access, we can map the questions to an SMS text. So if I ask you, do you feel you have a fever? Then we will turn that into an SMS text where you can answer yes or no, or whatever language you have. And then the answer will go back into the system as a result that can be evaluated. So this mapping between questionnaire on the graphical user interface and SMS texting has actually been done by us. We did that 4 years ago because we wanted to take exactly the situation into account. So if we need to get out in areas where there's only SMS coverage with basic phones, we can even do that.
Okay. Ashwak is asking a question. How do you filter the wrong inputs or data sets from the user?
Basically, we do trend analysis, and we can see if the weight suddenly shifts unrealistically high, it's probably a prank or an error. And then we take away that measurement set from the set of measurements from the patient and ignore it. We write a message to the patient to verify that it was flawed and ask them to retry and redo the measurements to get more accurate data. Is one solution. Another solution is always to ask for data twice. So if you have a manual input situation like temperature, you will ask them to do 2 temperature measurements and input the temperature 2 times to get a reduced chance of faulty data.
Okay, so there is an interesting, fact. In India, we have an app called Araggo Bharat. So I have actually been through that application. It is asking questions to the audience and mainly the user, whether they are infected or not infected, with a question and answer session. I haven't seen the proper AI backend. So there is a question from Abhishek Kumar. He is saying that Araggo Bharat have got something like this. So can you enlighten on that? Abhishek, you can listen to him carefully. Araggo Bharat, as per my understanding, is a Q&A with specific questions to the people who are literate enough, who understand the language and who are, literate guys. But this kind of application that he is proposing or he is running, I mean, we are running, I should say, we have a face recognition system, you know. So when you turn on the app, you will actually recognize the face of the user. So even though if he's trying to say, I'm not affected, I don't have any kind of fever, or maybe I don't have any flu, well, it can actually detect using the AI backend. Henrik, can you put some lights on the technical process so that the people can understand how deep technology you guys have used? I mean, we guys have used.
Yeah, let me show you. So this is a screen capture from smartphone that uses a video signal to process. This is the reflection of red light off the skin of my face. And that means that this will work in any skin color situation, because it's looking at the reflected light and not anything else. So what this does is it uses an AI engine on the phone to evaluate the data that comes from the face about the red light and turn it into, through an AI algorithm, turn it into actionable data, which means that after having measured this for a couple of minutes, I have these kind of data that is submitted in my backend. And this tells me that if the respiratory rate is above 22, and if the respiratory rate is increasing over 2 days, because it means that my lung function is failing. And in the same time, I will see the saturation falling below 95, which is also indicative of failing. So no matter what they say and what they claim, they will be one of those who have to go into observation for actual COVID-19 symptoms. And this is available for people who aren't even are illiterate. That's not important. The important thing is that the data they collect goes into the platform, and if they are registered with their name, we will be able to find them and tell them that they need to seek a doctor in some way. I think that would probably, for the illiterate, that would require some changes to the system. Right now it's based on people being able to read or write. But there is no denial, because the actual system here will tell you if there is any symptoms that is worth looking into.
So there's a comment or compliment from Ashwak. He's saying a great app. Yeah, it is a great app. Come on, that's the reason multiple countries are using it, and government is actually accepting those kind of factors, and they are trying to we're trying to help the world. Well, if there is any, no more question, then I'll be more than happy to ask you a question from business perspective, Henrik. What is the business proposition that we have from our company to the partners? What is the partnership model that we actually go for?
So what we're trying to do, we have set up an NGO and trying to raise money to give away this for free. Unfortunately, it is not free. So I just want to ask a question. The app I showed you is also not free. It is developed in Israel, and they are not putting it out for free. But we do have an agreement with them that they will be matching our prices during the COVID-19 crisis to give an especially affordable version of this app to be put into our hands. So the offer that we are putting out is we are offering societies and governments in India huge discounts on large volume installations. So if you are, so the normal price for a Western European country will be something like 200 rupees per patient per month, or 200 rupees for the COVID-19. But in India, we're putting it out for a fraction of that price if the volume is high, because there are so many people in India. So we're saying like this: we want this to be able to reach out to the Indian people, and because there are so many people, we will only charge the lowest possible amount that can be charged for giving any patient access to the full system for the duration of the COVID-19 crisis. And of course, nobody will pay 200 rupees for that because it's too much money. But in the kind of volume we're talking about in India, this will be much more affordable at large scale, which means that the governments and organizations actually have this within reach to reach out to hundreds of thousands of people that are in the danger of being of getting COVID-19 and setting that up. So we're actually making that doable because we know in the India market is extremely price sensitive. So we're doing absolute all we can. And already now I have more than 4 different leads that have government level contacts in India that we are pursuing to get this to make this become a reality. But we need all the help we can get. What I must say is that this system is based on the fact that 200 nurses can monitor 100,000 patients. So there is a requirement for the government to enroll and find the nurses necessary for the effort of monitoring patients in their home. If they don't do that, it will be a self-monitoring app, which is also okay, but not as good and not guaranteed to save anyone's lives, because if nobody's looking at you, well, you can be in denial and nobody will take care of you anyway. So I think it's important prerequisite for this to be implementable is that the governments that does this also need to be able to bring the nurses to the call center.
Super. You're actually saving lives. Well, Rahul is making another statement. Lovely procedure for diagnosis. Rahul, you're from the similar industry. Could you just come live and turn on your video, and maybe you want to say something? Rahul, yeah. Yeah, we can hear you, Rahul.
Hello.
Hi.
Hello.
Yeah, we can
Hello,
hear
sir.
you.
Good afternoon. Yeah. So basically, when we have this kind of an application, then can we include holistic advices as well for the infected patients, like the advices that are going to improve their immunity and benefit them without any charges? Like I can see you are doing it for the purpose of helping people. So it is a free of cost advice that can actually help to counter the particular symptom that the patient is facing. So maybe we can try that approach as well. Free of cost advice is not going to harm anyone.
No,
What is your take
actually,
on this?
I think the way the system works is, yes, you can add anything into it, and so as long as the government has paid for the free use for one patient for the duration of the crisis, you have absolutely free range to do any kind of configuration, any kind of communication, any kind of advice. So you can actually put active messaging into the app to tell them, you should do this, you should be aware of that, you should do this. And then you can ask them questions, and depending on the answers, you can give them additional information. So if they answer, no, I don't know what to do, then you can tell them that we have to do like this. You can ask them, are you in a vulnerable group? Are you at age, or do you live in a close quarters? And then you can give them advice particular in that particular context and information that can add to it. There is also messaging in the app, so you can write back and forth to the clinical teams and answer questions. That can be quite overwhelming if it is used a lot. But you have to remember that we want to save lives, and that means we need to have this monitoring program to preemptively monitor people and find those who need the aid the most. And of course, having automated messages and having a feedback, this is also depending on answers, is a part of this procedure. The more you can put into a questionnaire tree and logic, the less manpower is needed. So you can put a lot of the advice into some kind of logic tree, so you can save a ton of people. And I think that's actually a very good idea, and that would be available to you if you have the system, of course. The only thing that is charged for is the access from the patient to the system. We don't charge for clinicians, we don't charge for use, and the government will pay for the hosting. So it's free to use as you see fit. And there's a lot of creative ways to make this effective by giving advice inside the app.
And in fact, you can practically check any kid as well. I mean, from a point of view of kids, they can't answer all those kind of question, and they can't go for all those kind of, processes. But yes, if you can just put the camera in front of the child, you can actually test it. It's a automated testing. That's the kind of technology that that we have. You know. So talking about the same, I think I have got another interesting question in my private message. So the question is there any option for that your backend server will crash if you get a lot of data? Well, I can answer that, but I'll put Henrik in that question.
Well, no, I will say no. And this is, of course, I haven't tried loading it with the population of India, but I will say this, that we have had 6 years to design out of any kind of bottleneck situation on the backend, which means that all the services that are running are stateless, which means that there are no data stored in the actual programs. Everything is in the database, which means on the processing layer of managing data that comes in, you can replicate servers horizontally and scale up to an all virtually unlimited processing capacity on the horizontal scale. And this is traditional cloud-based computing. Yeah. So now you will ask, can the database actually take all this? And they say yes, because each patient only answers 2 questionnaires each day. That's not a lot. So even in very large installations, that's not a lot of traffic on the database. And in the 6 years that we have been running this company on open source databases, we have never tried to restore the database because one of our system crashed. And this is the advantage of having automated deployment and automated monitoring, because you take away the human factor, you take away the bugs. So we haven't had any opportunity to try if it can be restored. Of course, the emergency procedures, we know it works when we restore, but we have never been in a production situation where we had to restore the database. So the availability is high, and the capacity for processing, well, it depends on how many servers can be put online in the Amazon's hosting center, but I'm guessing it's a lot.
Yeah. And super question answer. I think we are at the end of the conversation, and I'll be looking for. Okay, I'm getting a lot of private message. Well, he already shared his contact details in one of the slide, and in any case, I'll be putting this video in all the social media. You're open to connect him directly. I don't have any issues. But whatever you do, make sure you're doing some justice with the business part. Because the kind of I should say, giving process that we are doing, we are trying a lot to optimize the cost from the point of view of hosting, as well as developing the process and the kind of people that we have in the backend. It's a huge process, and certainly we are happy to help, ready to help, there to help the whole community, the whole world. And I believe, that's my personal belief, I'm not sure how many of you are going to agree on that. India, actually, I'm talking about India. India actually needs more testing rather than only lockdown. Lockdown is not going to help us to detect the COVID-19. Rather, testing would. Lockdown will actually penetrate it, synchronize it, maybe it will help us not to spread that fast, but with proper testing we can identify who is infected and we can maybe save lives. So our honest request, if you feel, if you wish to save some life, we are all there, all open to help the community, help the society, and the countries. Thank you so much. Thank you, Henrik, for your time and your lovely presentation. See you guys. Thanks for the lovely questions. Bye.
Bye.